Dr. Vuppalanchi is a good personal friend. He's a strong supporter of the AIHA. He's been present at every conference. His kids come and donate money. They do peer-to-peer fundraising. They spend their time here on a weekend where they'd rather be outside, I'm sure. He is also, as I told you, he's an expert with drug-induced liver injury. He's also a clinical trialist here at IU. He's also what I call him as the FibroScan guru. So it's an honor to introduce Dr. Raj Vuppalanchi.
Craig, you're in the wrong profession. He is such a showman. Sorry I wasn't there yesterday, but I sent my kids, and they came back and told me that they had a great time. So thank you for coming here. I hope you had a great meeting. Regina is there with some leftover fibroscans, so if you haven't picked up your fibroscans, please, you have them so I can walk you through the report. Okay, lots changed since I last spoke 2 years ago, so I'll walk you through in a very simple format. This was one of my patients who came from Lafayette, a 32-year-old woman from Lafayette with a diagnosis of autoimmune hepatitis, confirmed by blood test and liver biopsy. Somehow she was told that her liver stiffness that was mentioned on the ultrasound report, now mind you this is not a FibroScan, but it was mentioned on her ultrasound report that she had cirrhosis. But when she asked about cirrhosis from her liver biopsy report, it didn't show cirrhosis. So she was all confused as to why she's being given conflicting information from 2 different tests. Liver enzymes were improving on treatment, and she presented to us with questions. Did the liver biopsy help with the diagnosis with regard to autoimmune hepatitis? Yes. But did it show cirrhosis? And why is it not same as what the ultrasound showed? What additional information did my liver biopsy give with regard to severity of inflammation or severity of fibrosis? Why is the discrepancy between liver biopsy and liver stiffness that was mentioned on the ultrasound? What are we going to do in the future? Do I need a repeat liver biopsy? How can you tell me if the inflammation in the liver has improved? And can you tell me if the scarring in the liver has reversed over time? So these are some of the questions that she asked us, and I'll walk you through how we are able to respond to her questions. And I'm certain that these are the questions that went through your mind too. So let's switch gears and let's go back to basics. What are the properties of the liver that we hope to measure? Some of you know blood tests. We can check albumin levels that tells us how the liver is working, INR. Those are some of the things that can predict the functioning capacity of the liver. With regard to inflammation, we know AST, ALT. Those are some easy tests that we can tell with regard to inflammation. Structure, the CT scan shows smooth liver, nodular liver, ultrasound, MRI. These can tell you about the structure of the liver that can give us some sense with regard to whether cirrhosis is there or not. And of course, biopsy. And many of you know with regard to FibroScan, which measures the stiffness of the liver. The more the scar tissue, the more stiff the liver is, the more the inflammation, the more stiff the liver is. So these are all clinically available. These can tell you about prognosis, meaning it can predict whether the patient is going to get into trouble or not. It can tell us about treatment response. Liver enzymes get better with treatment. It is a response to the treatment. But we'll talk more about breath tests. We'll talk about HepQuant. And we'll also talk about MR elastography, which we are doing as part of clinical trials. And these may be available before we meet for the next meeting. So stiffness is a physical property. Liver is a smooth organ, but if there is inflammation in scar tissue, it becomes rock solid, and the more stiff it is, the more scarring it is. And we measure in terms of kilopascals. If you look at this picture, liver is inside a capsule. So as the fibrosis increases, the stiffness increases. But inflammation can also increase the stiffness. If there is a blockage in the bile ducts, some patients may have overlap with primary sclerosing cholangitis and autoimmune hepatitis. And if they have a blockage in the bile ducts, the stiffness may increase and may not necessarily be related to autoimmune hepatitis. There's some data with regard to if you get a FibroScan done within 2 hours or within 3 hours of eating a meal, it can increase the blood flow to the liver and can increase the stiffness. And if there is heart failure, there is a backup of pressure into the liver, and that can cause stiffness, which has nothing to do with scar tissue in the liver. Currently, we have a lot of options, and these are sneaking up on us and happening fast. For example, you have ultrasound-based measurement of stiffness, you have MR-based measurement of stiffness, and you have point shear wave, 2D shear wave, and many options. For example, we have the FibroScan that many of you are aware of. Then we have the MR, which may be available next year because it got a CPT code this year, and there will be a reimbursement with insurance coverage next year, so it may be ordered by your physician. And then we have the ultrasound. Very interesting. These ultrasound machines are already existing in clinical practice, and they want a piece of the market with regard to measuring the stiffness. So they are offering free software upgrade to radiology departments, and when a physician wants to go and tell the hospital administration, we want a FibroScan because we want to avoid a liver biopsy, the hospital administration is going to say, hey, we already have an ultrasound in radiology. They are getting a free software upgrade which measures the stiffness. So why do you want us to buy as a FibroScan? The radiologist is going to give stiffness as part of their report. So here, a patient from the Lafayette, her physician never ordered stiffness, but it was reported on the ultrasound report as part of their free upgrade in the software. And stiffness measured by one technique may not be the same as stiffness measured by other technique. For example, these are all the ultrasound-based stiffness measurements. You have virtual touch imaging from Siemens, you have from Philips, you have from GE, and you have FibroScan from Echosense. So the one she had was 2D shear wave elastography from GE, and a 7 kilopascals on that machine does not mean 7 kilopascals on FibroScan. So we are dealing with numbers all over the place depending upon the location of their hospital and them getting stuff done without anybody knowing why it is on the report. So what is it that we know on the elastography? It is very attractive for us because on a liver biopsy, you get a window of 1 in 50,000 piece, whereas in a FibroScan, you get 1 in 500. So you are getting a more area that you are measuring with regard to the stiffness. So sampling error may be lower. And that's why these technologies are very attractive because you're able to measure more area of the liver. But there's a nuance with regard to measuring using these technologies, is that the distance between the skin to the liver capsule, as Craig has pointed out, if there is a heavy patient with a BMI that is higher, then the distance between the skin and the liver capsule may be larger. And this technology is programmed to measure at a certain depth. And if it is not in the liver, it is measuring the stiffness of the subcutaneous tissue. And that is much higher than the liver. So you might get a false increase in the stiffness of the liver. For example, FibroScan was available in Europe for 10 years before it came to US. They had the medium probe, which measures at 25 millimeters from the skin. They could not get the FibroScan to US because of our average BMI being higher than the European. So it took them 10 years to come up with extra large probe, and that's when it got approved in US. But especially when we are using FibroScan for evaluation of liver stiffness in fatty liver patients, the BMIs are much higher, and even extra large probe may not be enough for us. So here we just submitted this data to a liver meeting. On the top, you see patients with FibroScan liver stiffness measurement on the y-axis and the fibrosis stage on the x-axis. If the skin to liver capsule distance is normal, you see the numbers going up very nicely, and stage 4 fibrosis, the liver stiffness is very high, and it's working as a good diagnostic test. But if you look at the bottom, where skin to liver capsule distance is high and increased, we have numbers all over the place because of the false increase in the liver stiffness. It's no longer differentiating. So you could have a stage 0 fibrosis with liver stiffness of 13 because it's measuring the stiffness of subcutaneous tissue and not the liver. So sometimes FibroScan done somewhere, technician has done it, and the physician is looking at the report, and he has to look at the propagation maps. But if he's just reported that, hey, I had a FibroScan done and my stiffness is 10, I don't know what to make out of it unless I look at the propagation maps. Regina has done this study with us where we fed patients. We just asked them to go to cafeteria, have a FibroScan, eat whatever you want, baseline FibroScan, and FibroScan every 30 minutes. And here we were able to show that liver stiffness increases after eating for up to 2 hours, and then comes back to baseline at around 3 hours. So if somebody had a big meal before their clinic appointment and we do a FibroScan, imagine 20% false increase in the liver stiffness and not necessarily related to underlying liver disease. MR elastography may overcome the problem with skin to liver capsule distance if the BMI is high. It may be worthwhile to do an MR elastography rather than a FibroScan. And here you have the red indicates more scar tissue. If you look at the here, so the scale is 0 to 8. And the more red is, the more scar tissue. You know that red is not uniform. Sometimes the scarring in the liver is not as uniform. So imagine if you got the biopsy here versus here, there could be a sampling error of 1 stage easily. And you also know the scale is 0 to 8. In the FibroScan, the maximum kilopascals is 75. In an MRE, it's 8. So MRE kilopascals times 3 is generally the kilopascals on FibroScan. So if you have a MR elastography and somebody says, oh, your liver stiffness is only 3, don't worry about it, but you have to multiply with 3, so it's 9 on FibroScan, whereas it's 3 on MR elastography. So numbers, you need to know which technology, which device is the kilopascals. People are already doing different things. This is one paper published recently using MR elastography for children and adults. Here is point shear wave elastography, another technology. So numbers are there. People are going to use different technologies, whatever is available to them. Please make sure that same device is being used each time you undergo and not keep changing the device and then get confused whether this change is related to the device, technology, or underlying liver disease. Normal liver stiffness is around 6.5. Anything less than 7, we think it is normal. And you will have cutoffs related to different technologies as to what means what. In general, 20 or above, we are worried about cirrhosis and portal hypertension. Some studies with regard to elastography in autoimmune hepatitis. Here we have patients who underwent FibroScan under 3 months and after 3 months. Under 3 months, you have a lot of inflammation on liver biopsy. ALT is high. So there is not much correlation between elastography and staging because most of the stiffness is related to inflammation. This is a new diagnosis. There's a lot of inflammation in the liver. The stiffness is mainly influenced by the inflammation. But after the inflammation is improved, where the ALT has come down to 37 on an average, it has a very good correlation with the staging. So now that the inflammation is gone, it is accurately predicting how much scar tissue is there in the liver. So many of you may panic if with high numbers, but it all may be related to inflammation. It's a new diagnosis. There's a lot of inflammation in the liver. Number may be high. So the patient who came to me, the stiffness was done at a time when their diagnosis was new. There was a lot of inflammation in the liver. So the kilopascals was indicating combination of fibrosis and stiffness and inflammation, whereas the liver biopsy was only showing the fibrosis was not as much as what the stiffness was related to on the ultrasound. So there are a lot of nuances on how to use the technology is great, but we need to understand how to use it and make it meaningful for that situation. These are some cutoffs with regard to stage 1 versus 2 or 4, 10.5 kilopascals. If you are looking less than 2 versus greater than 2, 12.1. If you are looking for F4, 19 kilopascals. But again, we have no idea with regard to the BMI in this cohort. So oftentimes, we need to look at our own institutional data, how is our patient cohort cutoffs working out. So, but these are some numbers. And here, you have liver stiffness that comes down as the inflammation is improved. These are how much the LSM can come down. Here, there is a patient who started off with 30, and it's 6 or 7. So that much of the stiffness was related to inflammation and not fibrosis. If you want to predict scar tissue in the liver, there are certain blood-based biomarkers, but FibroScan seems to trump the blood-based biomarkers. Here you see a nice cutoff with regard to as the fibrosis increases, the liver stiffness increases, but you also notice there is variability, and it is probably better to have a change over time rather than one-time FibroScan. That's why at our institution we do annual FibroScan, and we compare the change over time and not just liver tests. So we know that the inflammation is improving and fibrosis is improving over time. So we'll talk about emerging things. This is a test that we are doing as part of a phase 3 in a PSC clinical trial. It's called HepQuant. Basically, you give folate isotopes, IV and oral, and we measure how much of it is taken by the liver, and we get the ratio, and it gives us the functioning capacity of the liver. It's not radioactive, it's a cold isotope. Here you have the shunt. If the value is above 19, it is able to predict clinical outcomes with regard to ascites, encephalopathy, variceal bleed, better than regular blood tests, MEL score, platelet count, fibrosis, and it's non-invasive, 6 hours test. You can have it done over, annually or one time, or when the inflammation is all gone and you want to know where exactly the liver function is. I suspect it will be most useful in those who have advanced fibrosis rather than just minimal scarring and some inflammation. But it's a non-invasive test, and it got FDA clearance. It needs to get a CPT code and then get reimbursement. So there's at least 2 to 3 years before it will be in the market. Then you have the breath test. We are routinely doing this test as part of all clinical trials, but not commercially available for us to order. It does not have a CPT code yet. Here you drink half a glass of metacetine, and it's again a radioisotope. The metacetine is broken down by the liver into Tylenol and carbon dioxide. It's a low dose, not to worry. And then you breathe out the CO2, and it measures how much of CO2 you are breathing out over 6 hours. And for now, the amount of CO2 you measure at 20 minutes seems to predict how the function of the liver is. So this is actually measuring the quality of the function rather than AST, ALT, or albumin, or INR, which can be influenced by other things. This is another test called Enhanced Liver Fibrosis Test. It's been around in Europe for a long time. It's by Siemens. They didn't see much value to it, so never commercialized. But the investigators and physicians have been putting so much pressure on them, and they finally felt that it was worthy of them investing money to get it approved. We anticipate that it may be approved later this year. It's a simple blood test. It measures 3 proteins and gives a score. And this score seems like 10.3 cutoff predicts outcomes related to liver disease. So this could be one test where you get a sense with regard to the prognosis. And combination of FibroScan, ELF, liver tests, you may be in much more control of information with regard to the liver without undergoing a liver biopsy, and that may be where the future is, because nobody wants to get liver biopsies with regard to monitoring. Yes, at the time of diagnosis, things are unclear, things are happening, competing etiologies. We feel that we are more confident in committing someone to a lifelong treatment for now. We need to have all the information. So nobody questions the initial role of liver biopsy at the time of diagnosis, but for monitoring, it's not the ideal tool. And to answer questions with regard to, is my inflammation gone? Is my fibrosis improved? Which are very valid questions. And what do I see my future 5 years from now, 10 years from now as a prognostic tool? We are getting there, and we may be there pretty soon with a combination of ELF and FibroScan or MR elastography. So that's, I think, where I want to stop. So liver stiffness, I want you to know the timing of liver stiffness measurement is important. There are other factors that can influence liver stiffness that are not liver related. It's a great non-invasive tool for monitoring. But fibrosis and inflammation can both influence the liver stiffness. And you can use it as a response to treatment. And we have emerging options with MR elastography, metastatin breath test, and HepQuant. So thank you for your attention.
So maybe we take a little Q&A
Okay.
for Dr. Vuppalanchi and myself, and if Dr. Assis would be willing to participate as well, kind of the final Q&A for any of the things we've just talked about or discussed.
I'm looking at my sheet for my FibroScan, and there are two numbers.
Yes.
The first one's a large number, and then
Yeah.
can you just tell
Well,
me
if
what
you
that
look
first
at your
number is?
FibroScan report,
Yeah, maybe, do you want to walk them through? Walk them through the report?
yeah.
Okay.
I don't have a, but you can look at your report and I'll walk you through it. So. Oh, no color, Regina? Everybody has color. Oh, I'm sorry. Okay, sorry. So here's the FibroScan report. We are very fortunate to have Regina. She probably is the world's most experienced FibroScan operator. And year after year, she volunteers and offers her services for free. She went to Houston for another nonprofit conference for rare disease. She's going to Kenya to do fatty liver in Kenya, right? Yeah. So she does great stuff. But coming back to the FibroScan report, let's look at the orange number. It says elastance E, kilopascals. The two-digit number, some number 5.7 I have here. And then you look at IQR over median, 11% is what I have. So as you know, Regina took some measurements, but we need to have 10 valid measurements. And then the median is what is reported on this report. You don't want the numbers to be too much different from each other. So we look for an IQR over median less than 30%. If it is more than 30%, there's so much variability, I can't tell which one is the correct number. So I look for IQR over median less than 30%, and I have 10 measurements, then it's a valid report. Then I look at 5.7, and that tells me, okay, less than 7 is normal, and more than 20, I'm worried about cirrhosis and portal hypertension. But then I need to know, is this a new diagnosis? Is this what's the ALT? You have to interpret this number in the context of the clinical scenario. Then completely separate from this orange number is the blue number, or aqua. This is the controlled attenuation parameter, CAP. It's decibels per meter, and it's a 3-digit number. Max is 400. Basically, it is telling us how much fat there is in the liver. Normal is 250 or below, and max is 400. So what is the value of CAP in a patient with autoimmune hepatitis? Sometimes it might give us a clue if there is overlapping non-alcoholic fatty liver disease, or it might help us appreciate if somebody is on prednisone, they're gaining weight, and they have fatty liver. It might make us go in very strong and feel that prednisone needs to be tapered as soon as possible. So there are some pieces of information that we are able to use from CAP. Now, there was a study. We wanted to look at effect of CAP on the progression of autoimmune hepatitis. I don't know if we could conclude based on the limited data set we had, but that is something of interest. If you have concomitant fatty liver, would you have progression or difficulty in getting autoimmune hepatitis under control? Now, another thing that CAP may help us is autoimmune hepatitis patient coming with stable doses of Imuran, whatever. IgG is normal, but liver enzymes fluctuate 70, 80, and we are scratching our head, is this autoimmune? Should I be increasing the Imuran dose? But if I see a CAP of 300, I'm more comfortable saying, hey, I think the ALT increase is from fatty liver. I'm not so much worried about autoimmune hepatitis. I'm not going to increase the Imuran dosage at this time. I might recommend 10% weight loss over the next 6 months to 1 year, and then we will see how the ALT numbers pan out. So it helps with regard to managing some features associated with autoimmune hepatitis.
Great.
Thanks.
So questions regarding that then? Range of blue?
Range of blue, orange.
For stiffness.
Yeah. It can go from 1.5 to 75. Less than 7 is normal. Generally 10 or greater, we are thinking of stage 2 scarring. 15.5 or greater, we are thinking stage 3, stage 4. Greater than 20, we are thinking cirrhosis and portal hypertension, assuming that there is no inflammation. Yeah. Well, if you look at the pictures, those 10 pictures there is on the report, those are propagation maps. So when I look at the report, or any of us at IU look at the report, we actually don't just look at the numbers, we look at the propagation maps, and we get a sense with regard to whether the skin to liver capsule distance has played any role. So if we see that there is increased skin to liver capsule, we might say that the report is not reliable. And all our FibroScan operators, they write the BMI of the patient on the report. So I know the BMI when we are signing the report.
Other questions?
On both sides, the blue and the orange, there's an IQR.
Yes.
What is that?
Interquartile range, whenever there is a median, it's an interquartile range. So we use IQR over median only for the orange. It doesn't matter for the blue. It's like a quality control metric right on the report.
What is the BMI, the least amount?
Yeah, good question. Generally 35 or above, we kind of get into trouble. But we've had BMI 40, the liver was behaving that day, and we got great pictures. So it depends on that particular, and then the expertise of the technician. We stretch to get the best shot at the liver.
Question?
Yeah, so if your turquoise number is high, does that mean that you need to lose weight? Would that bring it down? I'm
Yeah.
just trying to figure out, like, mine's really high, and I'm like, man, I don't feel like I eat that healthy. So I'm like, wow, what am I doing wrong?
Well, we are increasingly understanding the pathophysiology of fatty liver. There's a gene that's been linked to presence of more fat. then the constituents of the diet, generally more carb, more fat in the liver. And we have lifestyle studies that showed that 10% weight loss in 1 year the fat disappears. So mere presence of the fat does not indicate something ominous, but it's a very dynamic thing. It's not a permanent thing. So we can easily change the cap by lifestyle. But there may be drugs for that.
Are you saying in your answer to her that you can't tell by looking at, just how fatty a person is, that doesn't necessarily correlate exactly with how much fatty liver they have?
Oh, you can, if you do a FibroScan on a sumo wrestler, they don't have any fat. So it's a visceral versus peripheral fat. Yeah, the sumo wrestlers don't have fatty liver because their fat is all subcutaneous.
Question?
So
So the question is, if you
Yeah.
have fatty liver on your FibroScan as well as autoimmune hepatitis, do you now have 2 liver diseases?
So not all fatty liver is NASH. NASH is a histologic diagnosis. For NASH, you need to have fat, inflammation, and damaged liver cells, ballooning or lobular inflammation. So mere presence, 1 in 3 in US have fatty liver. They drop weight, fat disappears. So only 10 to 15% of them have NASH. So mere presence of fat does not necessarily mean there is NASH. And NASH is the one that causes damage, not plain fat. So FibroScan does not tell us if somebody has NASH or not.
Question?
Yes. 10% is the key.
Can I ask a question? Whose was this first FibroScan they ever had?
Oh, wow.
Do you guys, impressive, right? So I think I want everybody to see that. So again, this conference has provided that, EchoSense obviously, but this is not technology that's everywhere. So again, I think this is a really novel perspective. Maybe to transition that to Dr. Aziz and how they use FibroScan in management at Yale, because it may be different as well.
Yeah, we certainly don't have the ongoing studies evaluating this as the center here, which is excellent. Anecdotally, in my own practice, I certainly do use it, as I think I mentioned in one of the earlier talks, when we have a diagnosis and we know what's going on, and we want to follow it over time to see if the interventions, whether it's for fatty liver, hepatitis, viruses, for example, or autoimmune hepatitis, if they're having a positive effect. And a positive effect is that by reducing inflammation from the underlying cause, that the scars can hopefully improve, then I would like to see that hopefully over the next few years. So I do get FibroScans every 1 to 2 years. There's some data that's now being looked at prospectively for PSC, in which an annual increase in the amount of FibroScan kilopascals, so in other words, the number, was a concerning sign that could lead to some worse outcomes. So I also look at this to see that things are not getting worse. And so I do use that as part of my practice.
That's great, thank you. Question?
Some of the doctors, they don't always want to take stuff that you brought in. If our doctor doesn't want to accept this as official, can they request it from IU to get it for part of our official record?
So again, that would be the same official record that's scanned into our record. So you have the official report.
Okay, so this one should be accepted.
It is. So providing that feedback to us, I am very interested in this in terms of you guys coming to a patient conference, collecting some data, and returning to your doctor. I can understand it. Again, if that doctor is probably worth anything, and just to take it into consideration. And maybe not believe it, because he doesn't know Regina. He doesn't know the technology we used. He didn't know if you were eating or not, despite what you said. So there are variables, absolutely, to question. But I think it's a part of your care. And it provides an awesome entry into some really important questions. If more care, more deliberate care, or advancement of care is needed.
My doctor wants feedback from this
All right, good. Question, Lori, and I'll get back there.
My doctor wanted me to have the FibroScan. And I would like to go back to the University of Alabama, where I go, to try to push to get the FibroScan. They do not have it there. Is there a contact person or an address that someone can give us so that we can do this? We can fight for this at our particular.
Dr. V will just buy you one, probably. No?
Again, your problem is not unique. Hospital administration looks at the cost, and you just have to make a case, either improving quality of care or show them the dollar signs that you're going to make money off this device. So one of the physician champions has to convince the administration about that. But most of the data is online. You go to EchoSense website, they have reimbursement, and their reps can tell how many patients you need to do the device to make them pay their bills.
How long does it take to progress to the next stage, or is it very patient dependent?
Yes. In chronic liver disease, where there is no treatment, it depends on the etiology of the disease. Autoimmune hepatitis is very unique in a way that if you control the inflammation, the body can repair the scar tissue. So we've had patients with a lot of damage completely reversed over time. So I don't know how to answer your question. Yes, it will progress in months or years if no treatment has been offered, or diagnosis has not been made, or that none of the treatments offered are working. But if you get the inflammation down, there is no reason to believe that it is progressive.
Just curious, I had a FibroScan in October, which, according to the results, I was at stage 3 fibrosis. We followed up with a biopsy in December, which put me at stage 2. So what is your opinion about the variances? I understand the biopsy takes a very, very small sample, but which would be more accurate?
Currently, biopsy is considered gold standard. Again, you saw the dots, they are overlapping. And then the FibroScan could be measuring combination of stage 2 fibrosis with inflammation, whereas biopsy is only showing you fibrosis. Awesome questions.
Another question.
So I understand that in my liver, I've been told that my left lobe is sort of small and shrunken and kind of sad, but my right lobe looks pretty happy. Would a FibroScan be still accurate? I mean, looking at that picture, I know it's just a pictogram, but if it's primarily measuring your right lobe, what does that mean?
So most numbers, our FibroScan is from the right lobe. The probe, if you want to measure in the left lobe, may not be calibrated to exactly measure in the liver. It could be going beyond the liver or before the liver. So the numbers may not be relevant to us. Your report of the left lobe not being happy is probably related to the initial insult where there was a lot of cell damage and collapse. And that's why it looks different from the right lobe. But there may not be any inflammation at this point. So it's mostly a structural detail and not necessarily what's happening right now. this is a consequence of the past, and I don't think it is unhappy at this time. It just, it's just the past.
Those are all great questions. Any others? Jess?
As far as getting the MR elastography covered, can you use the FibroScan result to say, okay, we've seen this number, can we get coverage for the elastography?
So it just got a CPT code. There is no dollar amount assigned for reimbursement yet. When we ask our radiologists, they just do it for free and charge you for a regular MRI, but they do elastography for free for us.
I think Dr. Assis has.
Yeah, we're becoming more familiar with it also after the CPT code. I've had 1 or 2 patients in which the FibroScan suggests a lot of scars or fibrosis, but enzymes are normal. There's no basis at all almost to suspect that, and that's an odd scenario. I mean, it can happen, and then I've been successful at getting an MR elastography, even more so because obviously there's a big difference between stage 3 and no scarring, and actually in the very few times that we do that, we haven't seen much on MRI. So I think maybe as a follow-up to an equivocal or a difficult to interpret result, that might be another way to do it.
That's great. Thank you, Dr. Vuppalanchi. I appreciate it. Dr. Assis.